Good afternoon, Dr. Bone with Yodo Channel, and of course,
I'm Dr. Lisa Tartaglia. Today, we are going to continue our serious illness topic about prognostication of illnesses, and this topic we're discussing is lung diseases. There are several different lung diseases which cause chronic illness and shortens people's lifespan. We're not going to focus on this video on cancer, acute respiratory distress syndrome, as well as acute infections. We're going to cover that in another topic. But the topics we're going to discuss are chronic obstructive pulmonary disease, emphysema, chronic bronchitis, pulmonary fibrosis, cystic fibrosis, bronchiectasis, bronchiolitis,
chronic bronchitis, the interstitial lung diseases, they all have one thing in common, that they're chronic illnesses, chronic lung illnesses, and they all progress over time. So the acute stuff is kind of aside, and of course, lung cancer is kind of aside. And we're not going to talk about these individually as like each individual disease process. We're going to talk about them in relationship to prognosis and prognostication and how we evaluate somebody to give a person that prognosis, to tell them this is where you are in the stage of your disease. But we're not going to talk about the mechanics of each one of these disease processes. Does that make sense?
Yeah, the mechanics of the disease process really, unfortunately, do not matter because once there's damage to the lungs, you cannot regenerate lung tissue, unfortunately.
Right. So your pulmonologist that's been caring for you, your family medicine physician, your internist, they have been giving you treatments along your disease course, and things change over time as we age. Everything ages. I mean, the sun is getting older. The Grand Canyon is, getting older. Niagara Falls is wearing out. So everything ages, and we're made of, blood and sinew and tissue. So we age more quickly than rocks do. Mm-hmm. However, the physicians you've been seeing have been trying to manage these disease processes, and certainly different medications are used for each one of those disease processes that we listed. But when the disease process reaches that point, now you are limited more with what you can do. And the physician is going to give you your prognosis as that disease progresses. And sometimes they're going to involve another team member. That's us. That's the palliative team. Because symptoms have gotten to a point where you need extra help with management.
Right. And the symptom burden of the disease has taken over. For example, with people with lung disease, they're going to have shortness of breath despite being optimized on inhalers. That's normally what is given as first line treatment. Also, steroid bursts can be ordered to kind of help people when they have exacerbations. And these patients don't return to their baseline after having a short burst of steroids. And sometimes the patients are referred to us after they no longer can tolerate inhalers. And what I mean by tolerate doesn't mean that they cannot physically take the inhaler because their disease is so progressed that it takes too much energy out of them to utilize the inhaler.
Or their lungs are so tight and so stiff that they can't inhale deep enough. I don't know if you've ever swam with a snorkel, but the snorkel is only a certain length, because if it was longer than that, you would only be inhaling and exhaling through that tube. You're not getting any extra air. Because I know as a kid, when I would swim as a kid growing up, I think, why isn't my snorkel, like 10 feet long so that I can go deeper into the water? Because then you're only going to be breathing out, maybe 18, 20 inches. You're never going to get any air. You're just pushing in and pulling out that same air. So when an individual has that advanced lung disease, now when they press on that inhaler and they inhale, they're not able to get that cloud of that medicine down into their chest. It just gets into their throat, and it's not, doesn't work that way. That the medicine needs to topically apply to the lung tissue, and that's why when you take the inhaler, you're supposed to kind of have your head straight, sort of tip back, so it's a straight shot in there. And when you press down on that thing and you get that little blast, it's supposed to form into a little cloud, and you are supposed to capture that cloud. And then hold your breath for a little bit so that cloud will get down into your chest. Yeah. If you just squirt it on the back of your throat, it doesn't do any good.
Yeah, and your lung tissue is like a sponge. So when it stops When it stops functioning like it should due to scarring or advancement of disease, the sponge just cannot expand and contract. It loses its sponginess.
It's just stiff.
Mm.
It's just a stiff lung tissue, and so you get symptoms from that stiff lung tissue. So the doctors are doing different tests all along the way. Of course, they get a chest X-ray, and that tells them how the lungs look sort of structurally.
Right.
Then they might do a pulmonary function test, and we talk about that in a different video, to evaluate how the diaphragm works, how the intercostal muscles work, how the sponge of your lung tissue works. They may have you do this pulmonary function test where, you go in and you blow in this big tube, and they see how much air can you pull in, how much air can you push out, how long is that breath, and those measurements give them a different set of data. They can also do a perfusion study.
Exactly.
Now, the perfusion study is where they look at how your body retrieves that oxygen from the air you inhale and you exhale. But much of the data about a lung performance is told by the patient to the physician based on their symptoms and their response to the medications. Certainly, they do a pulse ox where they put it on your finger. And, Dr. T was telling me, I don't want to talk about the pink puffer and the blue bloater. And so we're going to leave that out just to entice you to learn about what a pink puffer and a blue bloater are. But we can certainly put that pulse ox on your finger, and we can say, oh, yeah, they're getting enough oxygen. But sometimes people don't feel like they're getting enough oxygen, even though that little thing on their finger, that pulse oximeter, is telling them they're getting enough.
Right. And we've talked before about the paternalistic view of medicine. And sometimes pulmonologists can be very paternalistic if they're stuck into their tests and they don't look at the patient. For us as hospice and palliative medicine physicians, we're here to provide symptom management. So we evaluate the symptoms despite whatever the tests say. We really try to treat the whole patient, because a lot of times with pulmonary patients, they do experience shortness of breath. And they are on oxygen and they're still short of breath, and they can be short of breath at rest or with activity, with different types of walking. And that shortness of breath and that ability to not perfuse and get good oxygenated air into their lungs creates anxiety. So then we were treating.
It affects their quality of life. They may have supplemental oxygen that they use. Sometimes people need supplemental oxygen all the time. Sometimes they just use it when they're active. Sometimes they just use it when they're at rest. But to qualify for that oxygen, you may have to do a walking test.
Right.
But if the patient comes in and says, I'm using the supplemental oxygen, I had to use my inhaler 12 times yesterday and it just didn't feel like it worked, you need to consider maybe they're not getting that.
Exactly.
And maybe it's time for them to use the nebulizer. And sometimes patients have been so short of breath for so long, they're actually kind of used to it, and they don't even wear their supplemental oxygen anymore.
Their body has
acclimated
to the change, and they are okay without it. It's amazing.
Maybe they don't eat as much, because when they eat, they feel really full. And so they've lost weight. So it's easier for their body to get around. They don't need as much oxygen because they don't have as much tissue in their body. They're not lugging around the extra weight, and they are thinner. And that's a prognosticating sign for us that they're eating less. They're not using their inhaler as much. They need the nebulizer machine more because they don't get as good of result just from the inhaler. They may need chronic steroids because the burst steroids are no longer functioning for them. And so they get to where they need steroids on a daily basis. And so those aren't measurements, those aren't tests, those are subjective findings that patients tell us that can indicate that their disease is advancing.
Right. And it's very important to spend the time with your patients and evaluate them case by case, because some months they might not have as many symptoms as others, depending on pollen and the allergies.
Humidity.
Who's visiting, if they're around somebody that has pets and they're not used to pet dander. I mean, there's a lot of factors that play a part in their
How
disease
dusty
progression.
is their house? Do they live in a
Yes.
rural area and
Mhm.
during the summer when it gets really dry, it kicks up a lot of dust? In the Midwest, we had patients that some of them didn't have air conditioning. And so in the summer when it was really humid, they had more trouble breathing. In the spring when there was pollen, they may have more trouble breathing. So all of those factors can play a role in it. And I don't know if any of you have ever been short of breath, but I can tell you nothing
Mm.
induces panic and anxiety more in a patient more quickly than not being able to breathe.
Yeah. There are medications that you can use to help with shortness of breath, but anxiolytics or sometimes antidepressants that work more on anxiety really, really help control the symptoms because we're treating it globally and not just treating the actual symptom because sometimes it's very hard to get rid of the dyspnea, the shortness of breath altogether.
So I'm going to lean in real close because I want to impact people for this. I think it's really important to impress upon the physician the symptoms and how you're feeling. And I also think it's really, really important for the patient to follow those instructions. So sometimes a doctor gives a medication to a patient and the patient's like, I don't want to take that. You're going to get addicted to that. Whether it's oxygen, whether it's an anxiolytic, sometimes we even use opioids to reduce that. But if you can't breathe, you are in immediate distress. Your oxygen level might say it's fine, but you feel panicky because you can't breathe. Over long periods of time, that anxiety can make you extremely depressed and you feel overwhelmed and you feel boxed in. And long-term hypoxia or not getting enough oxygen to your brain makes your brain not work right.
So you'll notice changes in cognition for these patients. They might start to, you call mom or dad and they're not able to tell you what they ate for breakfast. They don't know what day it is. It's because they're just not getting enough oxygen to your brain. And over time, this creates a dementia syndrome. They're just not going to be with it if they're not properly oxygenated, and damage to the brain can be irreversible. You're not going to get them back to the way they were before.
So if you've got a loved one that has a lung problem and it's advancing, even though they're taking their medicines, maybe they're on the steroids, maybe they're using the nebulizer, and you start noticing little changes. They're not eating like they should. They don't want to get out of bed. They're not taking a bath. They're not changing their clothes. Sometimes when they say things, it doesn't make sense, or you're just thinking, the person that is in front of me is not the loved one that I'm familiar with. You know that disease is advancing, and we must help them help themselves because they're going to be resistant. They don't want to do anything because their lung disease is so advanced, they feel like they have a tenuous grasp on the ability to breathe. And like I said, nothing makes you more panicky than not being able to breathe. So they might not tell you, I can't breathe when I take a bath, but that's the symptom that they have. And so they maybe can't communicate with you because their brain isn't functioning right. They're not going to take a bath. I don't want to change my clothes. That's energy I don't want to use. I don't want to make a full meal. I don't want to eat a full meal.
Right. And I think it's really important for families not to judge their loved ones. I cannot tell you how many times I've met families and they're like, oh, she's just so lazy now. She doesn't want to do it. It's not that they don't want to do it. They just can't. They cannot expend that energy to do it because they are trying so hard and using all their energy to breathe. So that's why it's really important to have somebody like myself or Dr. Bond or other palliative physicians involved in the care for disease management, because shortness of breath is not something that's unfortunately fixable if you're maxed out on all your medications. So we need to do symptom control by using medications such as opioids, anxiolytics, and antidepressants to help symptom burden to hopefully provide a better quality of life for these patients.
And if the patient is to that point again, where they really are limited, have them evaluated for hospice. They can still be a full code. They can still go back to the hospital. But if they are eligible, what that means is you're going to get extra help to go into the home to the loved one. You don't have to take on the entire burden yourself to try to make them bathe, make them change, make them take their medicines. It is their life. Yes, you want the best for them and you want them here with you as long as you can, but now you got somebody to run a little interference for you. And I think that that extra help can really provide not just the patient extra help, but it can provide that family that extra help, because now you've got somebody else who, the aide is going to come in from hospice and they're going to take charge of that bathing. And if the patient can't get in the tub safely, they're going to take the bath to the person.
Exactly. They're going to do a bed bath. And then it takes you out of the family, out of the equation. And it's a hired helper, the worker from hospice. And that is their job description, is to bathe that patient. And they're going to find a way to do it that you were not able to do because you're the loved one and you can just focus on loving that patient. When disease progresses, such as a chronic pulmonary illness does progress, is really important for you to sit down and discuss the overall prognosis with your healthcare team and start having goals of care discussion with you, with how you would like your end of life to be, and also how what your what the wishes are for your family in the dying process. Include the whole patient, the whole set of family. A lot of times chronically ill lung disease patients have been intubated, unfortunately. When they have an infectious process, an acute process, they kind of know what that was like to be extubated, and so it's easier sometimes for us to have these goals of care discussion as if you were to have an illness that you were not going to be able to come off that ventilator. Is that the way you want to spend the end of your life? Or would you want to be at home? So you can try to get the DNR sign, try to understand if they want to be intubated, what that means for them. I've had patients that say, well, yeah, I want to be intubated as long as I don't come back as a vegetable.
Yeah.
We
don't know that. We don't know.
Right
now, we don't have a way to get a crystal ball out and say, well, this time when you're intubated, you'll be able to come off. You will be in a wheelchair or you will be bedfast, but you cognitively will still be similar to what you are right now. But then the next time we can tell from this that we don't have that ability yet.
I wish we did, right? We could retire,
but
we don't have that ability. And it's really important for the family to understand, if patients are already cognitively impaired, if they get intubated, that means that they're not having good oxygenation. They are going to come back probably
less.
Yes,
than
less
they are now.
So just always remember that.
And would they be happy with it? It's not about what you want for them.
Exactly.
It's about what they would choose, what they would want for themselves. And right now, in our country, we don't limit health care. So if they would want that, they're allowed to choose that. And that's their right to choose that they would or they would not. And that's so difficult for families because sometimes they get so caught up in the day-to-day. Today, you got to take your medicine twice a day. Today, you've got to do your exercise, because if you don't exercise, if you don't use it, you're going to lose it. So they get so caught up in the day-to-day thing. It's Tuesday, we got to take a bath today. Wednesdays and Fridays are the days we shave. So we get so caught up in that we don't think this is where we're going. This is what's happening. This is the progression. And then we're just overwhelmed when we reach that point.
Yeah, the critical breaking point, where the patients can no longer take care of themselves or an acute event occurs. So it's really good to look at the whole patient, try to notice if the patient's progressing, keep journals. We're all about taking notes, and really try to work with your healthcare team to ask the right questions. We hope that this educational piece was informative. We would love to hear any comments that you have. Please send us an email, drop us a line in the chat to let us know if any of you all have lung disease. If you have any questions, we'll be happy to elaborate on this further.
If your family needs help understanding how you feel when you're short of breath, let us know how we can help.
Yes. Thank you so much for joining us. Have a great day.
Bye now.
Bye now.